Hi guys, in today's video we're going to talk about infectious mononucleosis or kissing disease. So infectious mononucleosis is caused by the Epstein-Barr virus, which is the human herpes virus 4. The Epstein-Barr virus transmits via the saliva or because of the contact with the oral secretions of the patients or asymptomatic carriers. So what you must remember is that most of the patients suffering or infected with infectious mononucleosis are asymptomatic. So if there is contact between such patients, you might get infectious mononucleosis. Apart from that, blood transfusion and bone marrow transplantation are other sources of infection for this disease. So before understanding your clinical features or oral manifestations, laboratory findings or treatment, it's important to understand the pathogenesis of this disease. So now coming to the pathogenesis of this disease. So when the saliva gets transmitted from one person's mouth to the other person's mouth via kissing or intimate contact, the Epstein-Barr virus reaches the oral cavity. Now inside the oral cavity, the Epstein-Barr virus, which is EBV, loves the epithelium and the B cells. So it nicely goes and attacks the epithelium and the B cells. Where are your B cells located? They are mainly located in the tonsils. So the Epstein-Barr virus goes and attacks your tonsils. So after this, these B cells become infected and they can later go and transmit via the bloodstream. So after they enter the bloodstream, they would go to the other lymphoid tissues and cause infection in the other lymphoid tissues. So this is very important to note. So how do you remember the things that EBV loves? It loves epithelium, that is E, and it loves B cells. So where are the B cells present? They are present in the tonsils. So then once the Epstein-Barr virus goes to the B cells, it attacks them and the B cells become infected. Now once the B cells are infected, they enter the bloodstream and they can now go to the other lymphoid tissue and cause infection in the other lymphoid tissues. Alright. So yeah, this is like a diagrammatic representation where these are your Epstein-Barr virus and they have attacked the B cells. So now after all this has happened, your body is not going to shut up. So your body is also going to react, right? So after some time, your infection, that is your Epstein-Barr virus infection, is controlled by a combination of antibodies and cytotoxic T cells. So your body gives out antibodies which are very specific and it gives out cytotoxic T cells. So the antibodies are going to go and kill the virus and the cytotoxic T cells are going to go and kill the infected B cells. So this entire procedure takes about 4 to 8 weeks to finish, and most of the patients are asymptomatic because your body has handled everything. Your body has given out antibodies, your body has given out cytotoxic T cells. Alright. So this is all about the pathogenesis. Now coming to the clinical features of this disease. So the peak incidence of infectious mononucleosis is 15 to 20-year-old age group. The common clinical features that are seen are fever, chills, sore throat, cough. Now why is there sore throat? It is because of pharyngitis and tonsillitis. So if you remember the pathogenesis, this becomes very easy. We also see nausea and vomiting. We also see lymphadenopathy. So lymphadenopathy is bilateral and symmetrical and it mainly involves the posterior cervical group of lymph nodes. Now why is that? Obviously because the pharynx and the tonsils drain in the cervical lymph nodes. Alright, so that's the reason you would see lymphadenopathy mainly in the posterior cervical group of lymph nodes. And these lymph nodes are tender, mobile and discrete. Apart from this, you also see splenomegaly, which is seen mainly in the second or third week of illness. Hepatitis and skin rashes can also be observed. So these were the features that were very common, that is fever, chills, sore throat, cough, nausea, vomiting. Apart from that, we also see lymphadenopathy, splenomegaly, hepatitis and skin rashes. But you must remember that most of the times the patients are asymptomatic. So all these features can be seen, but most of the times the patients are asymptomatic. Alright. Okay. Now we come to the oral manifestations of this disease. So as we saw, the Epstein-Barr virus first comes into the oral cavity. It is transmitted via the saliva. So there are some symptoms that could be seen in the oral cavity. For example, we can see acute gingivitis. We can see stomatitis, which is the first sign of the disease in patients with oral manifestations. So if the patient is having oral manifestations, the first sign is going to be stomatitis. We can also find white or grey pseudomembrane in various areas of the mouth, ulcers, necrotizing ulcerative gingivitis, edema of the soft palate and the uvula, palatal petechiae, and petechial hemorrhage of the soft palate near the junction of the soft and the hard palate. So these petechial hemorrhage, they are pinpoint petechiae which are numbering from a dozen to several hundreds, and they appear few days after the other symptoms and persist for 3 to 11 days and then fade gradually. So this is important to note. So they will appear few days after the other symptoms have happened, but they will go away after 3 to 11 days. Alright. So we saw gingivitis, stomatitis, pseudomembranes, ulcers, necrotizing ulcerative gingivitis, edema, petechiae, and the petechial hemorrhage of the soft palate and the junction of the soft and the hard palate. Coming to the laboratory findings. So the laboratory findings are kind of important. Now, do you remember there were lymphocytes, right? So in the pathogenesis, we saw that there were lymphocytes, that is your B cells, that were getting affected. So in this disease, what we observe is lymphocytes that are enlarged. So there is lymphocytosis, that there is increased lymphocytes that are present, plus there is atypical lymphocytes. So the lymphocytes that were, these are normal lymphocytes, right? But the lymphocytes in infectious mononucleosis have a larger size, that is, they are larger than normal lymphocytes, and they have a lot of cytoplasm. Apart from that, they have vacuoles and dark chromatin with indented cell membrane. So this is very important to note. They have larger than normal lymphocytes with plenty of cytoplasm. Now, as I told you, I would tell you why this is called as infectious mononucleosis. Because we find an increased number of lymphocytes which have a single nucleus. So that's the reason it is called as infectious mononucleosis. Because these cells have one nucleus and we see a lot of lymphocytes in this disease. Then apart from that, we also see heterophile autoantibodies. Now there's a frequent MCQ that comes in from this topic. So they would ask you which test is used for detection of infectious mononucleosis. So you have to talk about the Paul-Bunel test. So that is because we see heterophile autoantibodies which are present in this disease. So the test for heterophile autoantibodies is positive in 90% of the cases during the 3rd week, and the test that is used is Paul-Bunel test, which is used for detecting these heterophile autoantibodies. Apart from this, you also see other antibodies which are IgG and IgM, which are against the viral caspid antigen, and there are antibodies to the early antigen, which is anti-EAD and anti-EAR. Now, apart from that, we could also check for the Epstein-Barr virus DNA by the polymerase chain reaction. Alright, so I think you should remember this point, and you should remember the Paul-Bunel test for an MCQ point. Coming to the treatment. So the treatment of infectious mononucleosis is simple. You need to ask the patient to rest and avoid excessive exertion. We could also give NSAIDs, that is non-steroidal anti-inflammatory drugs. Glucocorticoids like prednisolone are given when there is airway obstruction, autoimmune hemolytic anemia, severe thrombocytopenia, and prednisolone is not really recommended in uncomplicated cases. So only if there is a complication like an airway obstruction or hemolytic anemia or severe thrombocytopenia would you give glucocorticoids. And apart from that, you need to ask the patient to avoid sport activities for few weeks until the splenomegaly is resolved. So if the patient is having splenomegaly, which was one of the clinical features here, so you need to ask the patient to rest. So that's it about this topic. For a quick recap, let's review some pointers that can help you remember and make the complete chain. So infectious mononucleosis is caused by the Epstein-Barr virus. The source of infection is saliva, blood transfusion, and bone marrow transplantation. Then we came to the clinical features. There were very common clinical features, that is fever, chill, sore throat, cough, nausea, vomiting. Apart from that, we could also see lymphadenopathy, splenomegaly, hepatitis, and skin rashes. Then we came to the oral manifestations. The oral manifestations are not really specific, but you can see gingivitis, stomatitis, pseudomembranes, ulcers, NUG, that is necrotizing ulcerative gingivitis, edema, palatal petechiae, and petechial hemorrhage. Then we came to laboratory findings where we spoke about lymphocytosis, and that's the reason the disease is called infectious mononucleosis. There is also heterophile autoantibodies that are present, and you detect them by Paul-Bunel test. We also see other antibodies, and we can also detect the EBV DNA. Then we came to the treatment. You just have to ask the patient to simply rest, not play any physical sport. You can give him NSAIDs, ask the patient, and if there is a severe complication, you could give glucocorticoids. So that's it about this topic. I hope this video helped you a little bit, and I'm hoping you like the concept of mind maps. So if you like it, you should go ahead and make one for yourself.